said, my name is Danielle Cousineau. I am the clinical coordinator at Insite, which is one of Vancouver's supervised injection sites. It makes me so excited to get to say that because we now have 2 in Vancouver, which is amazing. I'm also the clinical coordinator for Onsite, which is a detox facility in transitional housing. My background is as a nurse, and I did start on the front line working at Insite for a number of years before I became the clinical coordinator. Though my job is technically classified as mental health and substance use, my role expands much beyond the limits of substance use and mental health. I do a lot of work in primary care and public health, and in kind of dabbling in emergency nursing as well. The primary purpose for why Insite was opened, some of you may know this, I'm sorry if I'm repeating myself, but was to reduce overdose fatalities and to reduce the spread of infectious disease such as HIV and hepatitis C. And so those really are the kind of core roles that nurses at Insite have. So what that looks like on a day-to-day basis is you're working in the injection room. You've got 13 booths where people are injecting various substances from opiates to stimulants to psychedelics. And you're providing clean supplies. You're teaching people best practice on how to inject. Just as a side tangent on that, you're not coming in, I get asked a lot of times, what happens if somebody comes in and they've already got their drugs in a syringe and they walk in and they've already got it all prepped? What do? Do you make them pour it all out and you have to make them go through the whole process? That's not what we do at Insite. We're really about meeting people where they're at, and it's harm reduction. We're not going to eliminate every single risk that there is with injection drug use, but what that looks like is having that person step through our front door. Even if they've already pre-prepped their drugs, we don't know how they've prepped it, we don't know if they use sterile water, them walking through that front door is them taking one step towards reducing their harm. If they have an adverse reaction to their substance, we're going to be able to intervene. And when they come, maybe for 6 months, maybe for a year, they're constantly coming in and they're bringing their substance with them. Maybe one day they're having a really tough time finding access to a vein, and so they ask for help. While a nurse is in the booth with that person, they are helping them find a vein and they're able to prompt them, well, hey, if I use an alcohol swab, it's going to really help me find that vein. Can I use an alcohol swab on you? That's great. And so then, maybe I interact with that person another 10, 15, 100 times, and then I see them in their booth and they're using the alcohol swab on their own. It's those really small incremental changes that we really have to celebrate in our work. Otherwise, I think we all get very frustrated because we're working with people who are extremely entrenched in their substance use, who are often suffering from mental illness that isn't being treated appropriately. A lot of people are self-medicating for mental illness, for chronic pain. The number of people I see walk through our front door who have severe burns to their entire body. They were prescribed morphine for 6 months. It's natural that your body is going to build up a tolerance to that opiate. That's just how our body works. Every time they're taking that morphine, they aren't taking away the pain, so they ask for a little bit more. Then their doctor gets scared and they cut them off cold turkey. Well, that person's still experiencing that chronic pain, and what are they going to do? They have to go to illicit sources for that drug. And so we do see a lot of people who are in those kinds of circumstances. We see a really wide range of people come through that front door. Beyond that task of helping someone in a booth and intervening during an adverse reaction, the undertones of all the work we do is creating relationships with people. And that's really at the heart of the work that we do. And it's so important. And if you're interested in working at Insite, you really have to have a passion for it. You have to have a passion for connecting with people, for preserving dignity, for restoring people's respect in themselves and their sense of self-worth. Because every time I'm in a booth with somebody and I'm prompting them to use an alcohol swab or helping them find a vein or showing them how to prep their Cadian, I'm also asking them, how's your day? Did you see the latest debate in the US primary? How absurd is that? And that just human connection is huge. Because a lot of the people we see are people who aren't accessing the traditional healthcare system. They aren't accessing our hospitals. They aren't accessing our clinics. unless they're on their deathbed. Whether it's they haven't been accessing for days, weeks, months, years. A lot of them have suffered really negative experiences trying to access our traditional healthcare system. Don't get me wrong, we have a wonderful healthcare system, and I feel so lucky to live in Canada. But not everyone fits into that perfect box that our healthcare system forms for people to access care. And so for a lot of people, we are that first point of reaccess. And so when that person comes in through the door and I see that skin infection on their arm, and my nursing brain's going, oh man, that person needs some antibiotics, because if we don't treat that, I'm going to start seeing streaking up their arm, they're going to get sepsis, maybe endocarditis, and they're going to have to end up in hospital. But that's not what comes out of my mouth. If that's what came out of my mouth every time I saw someone with an early stage skin infection walk in the door of Insite, nobody would come. Because they'd be like, stop nagging me, God, I know. They know that they need to deal with that, but maybe the day the person walks in and I notice that skin infection, they've just been evicted from their housing and they haven't slept for 3 days because they've had to be using crystal meth, because if they fall asleep, someone's going to rob them and steal all their belongings they have left. So if I haven't slept for 3 days, do I really care if I've got a small infection on my arm? Not really. And so by meeting people where they're at and by asking them what's going on for them, is there anything I can support you with right now? I help that person get a shelter bed for the night, on a good night. Some nights I can't find a shelter bed for them, but at least I try. At least I work with them to try and work towards a better solution. I can work on a housing application with them. Once that's been addressed, maybe it's a day, maybe it's 2 days, 3 days, they come back, they say thank you. By the way, this has been really bothering me. What do you think's been going on with this? And so by respecting that person's priorities, it allows them to feel empowered. And housing, it's a basic need. Can we really expect someone to take their antibiotics if they don't have a roof over their head and they can't have 3 square meals a day? I don't know if I could do it. I have a hard enough time doing it, and I have a roof over my head and a full-time job. And so that person's able to come back and ask me for my advice around that. I'm able to assess them, and then I'm able to refer them into primary care. Or maybe they don't feel comfortable accessing the clinic, and I can call up an outreach nurse and say, hey, can you come by the site? I have someone I'd really like you to meet, and we can make that introduction in our space where we've been able to develop that safety for that person, for them to access care. And maybe the first 5, 10 times they meet that primary care nurse from another program, it has to happen inside our site because we kind of create a little bit of a safety bubble for them. But once that relationship is formed with that other program, then they start meeting in a coffee shop. Then they start meeting in the clinic. And so we're just really the first step in entering a spectrum of services that are being offered, and a first step in re-engaging people in that process. I really like ranting with this. Went off on a tangent. So kind of to bring it back down to, because I'm sure you guys are interested in kind of the clinical skills that nurses need. I could rant about therapeutic relationships for hours all the time. But in terms of actual nursing skills, there is harm reduction teaching. You don't learn that in any other job. You don't learn to help someone cook their crack cocaine for injection in any other job. That's not a skill we expect people to come with. Really good skills to have in other hospital settings. You can learn to do venipuncture. You can learn to do IV starts. Those are really key skills in learning how to find venous access for people. That's one of the things I spend so much time doing, because a lot of the people we're working with at Insite are people who have been using for 10, 20, 40 years. And after that many years of accessing veins, you're not going to have a lot of options left. I haven't injected drugs, and I have one vein. Literally every time I need someone to draw blood, it's like, this is where you're going. There's nowhere else in my body. But, so trying to develop that skill and that knowledge around getting creative. I one time drew blood from the backside of somebody's knee, because literally they were like, you literally have to find somewhere where I can't reach, and that's the only spot where there's going to be a vein that you can access. So developing those skills through blood draw, through IV starts, is huge. Overdose intervention, emergency interventions are huge. We see people coming who react to substances that they inject. Common reactions, opiate overdoses. That's, we've been open almost 13 years now. When we first opened, the first 10 years we were averaging about 30 overdoses per month. Works out to about 1 per day. With our current status, there's public health emergency has been declared. We are averaging 120 overdoses per day, or per month, sorry. Per day. 4 per day, so that's a 4-fold increase. And so that involves inserting airways, providing artificial respirations, administering medications, taking vital signs. It's actually surprising the number of times that you intervene in an opiate overdose and you find out that someone also has sepsis, or their diabetes had been unmanaged for a month and their blood sugar is 30.2. And it comes back to every single time something triggers us to interact with someone, we look for the whole picture, because we can pick up other things that are happening for that person because they aren't engaging in other aspects of care. We also have people who experience anaphylaxis. We have people who experience stimulant overdoses. And there's 2 main outcomes that come from that. We can have cardiac-related chest pain or psychosis. Psychosis is a really challenging thing to manage because we don't have benzodiazepines on site. It's a lot of psychosocial support, it's a lot of environmental management. For someone who's injected cocaine who goes into psychosis, we can manage them fairly well because the half-life of cocaine is fairly short. We might have to manage them for about half an hour, and then they'll come out of it and they'll be okay. Someone who's injected crystal meth, on the other hand, a lot harder to manage. Goes on for hours, can go on for up to 24 hours. And so much more difficult to manage the safety of that individual. But it's a very complex team response that we have to have for that. Other health emergencies, chest pain, seizures. And then we also have people who, because we're a site of access to care, who will come in off the street with traumatic injuries, blunt force traumas, pipes to the head, hit by a car, stabbed. And so there's a very wide range of management of emergency situations. Beyond that, there's a lot of kind of baseline nursing skills that are really fun. We all like our wounds at Insite. Our chronic wound management is very fun. And we have a wound clinician we liaise with, so we do a lot of that management. A lot of our nurses are STI certified. So what that looks like is you can do that education through BCIT. And when you're done that education, it's a couple-month-long course with a 3-day practicum. And then you can diagnose and dispense meds to treat uncomplicated sexually transmitted infections, gonorrhea, chlamydia, UTIs. It's kind of awesome because we don't have doctors. So it's kind of us or no one sometimes with people when they come in. So yeah, that's kind of what we do. In terms of advice, if people are interested in working in the area, really we have a really diverse group of nurses that work at Insite, and the diversity is actually really key to the site being successful because, we have nurses with backgrounds in emergency room nursing who have worked on cardiac care units, who have worked on acute medicine, who have worked in primary care, and we all come together and we share our knowledge. And so the expert in managing a stab wound teaches the rest of the team those skills so that the nurse who worked in primary care who has never seen somebody with a stab wound can feel more confident in that intervention. We also organize a lot of in-services and education sessions, bringing in experts to expand on the skills of our nurses because you really are a generalist. You are seen as a clinical expert. The staffing mix at Insite is registered nurses, mental health support workers, and peers. So when somebody comes in and they're complaining of a generalized pain to their abdomen, you're the person who's going to be doing that assessment and deciding whether they need to go to primary care or they need to go to emergency. And so that's another really key skill, and that's something that can be really well developed in acute medicine, in cardiac, or just your general assessment skills, just to really ground yourself in those. I know it's really boring when you get your patient in the morning, you do your vital signs, and you check all their systems. There's a reason that you do that. And it's a really important skill no matter where you're gonna end up nursing. So really ground yourself in that. The other thing, it's kind of general for anyone, any area you're interested in, but it particularly, I think it applies to Insite, and it's probably going to be said about every area you hear about tonight, is having a passion and expressing that passion. So if you're interested in working in an area, express that interest to people and be persistent. Don't give up. Don't send your resume in once and don't hear it and go, oh darn, okay, I guess I'm not going to work there. Those are the people who, if someone just sends in a resume, no cover letter, it doesn't show a lot of interest. I want to see that story behind you. I want to see that cover letter. Fire me an email, come in for a shadow shift. We often have people come in for 4 hours to spend time on site, because a lot of people support what we do, but it's very different to actually do what we do. Yeah, that's my spiel. Before I lose my voice completely. Do you guys have any questions? At the back?
For support, I was working with talking so closely, what kind of support and how did you go about, having a strong ground development? You know what I mean? How did you support?
So a strong grounding to come into this kind of work?
Yeah.
So whenever we're looking at new applications, we're looking for people who have experience in the community, and usually have at least a year working in some kind of acute setting, whether it's neurology unit, acute general medicine, cardiac, some kind of setting where you're going to be in a high pressure environment, because you need to be able to just think quickly on your feet. And generally experience in the community as well, whether that's through volunteer work or through a clinical placement or through, in nursing school. I'm not familiar with Langara, but I know I was able to tailor some of my projects towards my interest of working in this area. And I was able to do research, and I was able to do community-based projects. And so those kinds of things that show that interest and passion are really important.
Do you guys need volunteers?
We do not. I get that question often. Unfortunately, we don't. Because we have to operate with an exemption from the federal government around the drug laws, it's really complicated to get to work there in terms of the process of applying to the government and getting record checks, that we can't sustain a volunteer program.
I know that some of the nursing programs offer tours of Insite. I was wondering how we might be able to access that if we're all moving up.
Send me an email. And those kinds of things can get arranged. And that's the same thing if you're interested in doing a couple, doing one of the 4-hour shadow shifts. Shoot me an email with some dates that work. We usually get pretty full. There's only 2 nurses on per shift, and so we have to limit it to one person who's doing some sort of shadowing per day. Just the nurses aren't overwhelmed. So give a month's notice, and we can usually find a date that works. You have a question?
Yeah, I was just going to ask about what are the kind of hours to expect as a nurse working in that community setting?
Yeah. So at Insite, the site is open from 9 a.m. until 3 a.m. And so that's split into 2 shifts. So your day shift is 8:45 a.m. until 6 p.m. and your evening shift is 5:45 p.m. until 3 a.m. But for all of our casual nurses that get hired into Insite, they get pooled into 2 of our other sites. One of them being the detox, which is the 2nd floor of the building, which I neglected to talk about today. Everyone's way more interested in Insite. Anyways, and the detox, it's 12-hour day shifts, 8:30 to 8:30. And then the other site is called the Community Transitional Care Team, which I think doesn't get enough credit for what it is. It's an amazing project. It's a subacute medical unit embedded in an SRO in the downtown east side. So basically it's people who are high risk of leaving hospital, AMA, who are on long-term IV antibiotics for spinal abscesses, endocarditis, osteomyelitis, like recent amputations, things like that, where they need care for at least 6 weeks, who are often living with active addiction and complex social circumstances, often aren't housed, and so they come in, and it's a 10-bed unit, basically, that's 1 floor of the SRO. Everyone has their own room, their own bathroom, and it's 24-hour nursing care, so it's 12-hour shifts. But it's an amazing project.